Partner med kongressen, og det betyder, at vi får lov til at svinge mikrofonen derude. Vi har delt op i 2 podcasts, og podcasten i dag, det er så den anden ud af 2, og vi gjorde det, at vi samlede de engelsksprogede podcasts sammen i en for sig, og alle de dansk, svensk, norske en anden for sig. Så i dagens afsnit, der er det så de 3 engelsksprogede interviews, der kommer med. Ja, det er det, vi har i dag. Jeg er vært Anders Nedergaard, a.k.a. Dr. Muskel, og man skal være velkommen til at skrive ind med spørgsmål eller kommentarer til podcasten, og det kan man på afn@andersnedergaard.dk eller på vores Facebook-side. Før vi kører de enkelte interviews, der vil jeg lige fortælle lidt om, hvorfor det er, at jeg har valgt at svinge en mikrofon i ansigtet på dem her. Og den første af dem, som kommer her om lidt, det er Robert Jan de Vos, som er læge og Ph.D., og han holdt en del oplæg omkring tendinopati, altså de her irritationstilstande i senerne, og specielt akillestendinopati. Men tendinopati, nej, nu skal jeg passe på, hvad jeg siger, det er ikke altid det samme, men rigtig mange af, det er måske den mest forekommende sådan, skavank, man oplever med relation til at have et træningsliv. Og jeg vil sige, ja, det har jeg da personligt selv. En meget stor del af tiden, der er sgu altid en scene et eller andet sted, der sådan knirker lidt. Men så bliver det heldigvis bedre igen. Så jeg fangede Robert Jan de Vos med mikrofonen her. Der har været fest aften før, så hvis han lyder en lille smule mør, så er det så det derfor. Men han har lige holdt et indlæg, der hedder Risk Factors and Management of Achilles Tendinopathy, som var sådan lidt mere, hvad skal man sige, helikopterperspektivagtig på det her med tendinopatier. Og han er en stor kanon inden for det, så det er jo en ekstrem relevant problemstilling. Specifikt akillestendinopatier er jo noget, der er meget almindeligt blandt løbere specielt. Men tendinopati, igen, al den stund, at det er så almindeligt i forskellige former i sportsfolk, så er det noget, som jeg tænker, som jeg tænkte, har en stor relevans for aktive mennesker, og dermed også Fitness MK-lytterne. Han kommer her.
Jeg er på Sportskongres, og jeg har fået fat i Robert Jan de Vos, som har holdt oplæg her lørdag morgen på Sportskongressen omkring sådan, hvad kan man sige, paraplyperspektivet på tendinopatier, altså irritationstilstanden i senerne. So first of all, thank you very much for taking the time to talk with us. So before we get any further, can you just give us your full name, your title, and your affiliation, so all the formalia is in place.
My name is Robert Jan de Vos. I'm a sports physician and scientific researcher at the Erasmus Medical Center in Rotterdam in the Netherlands. And I'm also club doctor of Excelsior Football Club.
And thank you very much for taking your time to talk to us. You just give a talk on tendinopathy in here. The listeners of the podcast is not all physiotherapists, or a lot of them are just enthusiastic fitness goers. And I know we have a lot of listeners that are not quite as young anymore, and they may be more prone to having these pain in their tendons. Can you give a rundown of your talk this morning to our listeners?
Yeah, so I think it's good to start with the fact that we are currently running a Dutch multidisciplinary guideline process, and I think we will finish it this year, and the concept phase is already done, so we have a lot of knowledge that we've gained. And I think first of all it's about establishing the correct diagnosis of Achilles tendinopathy, and what we found is that you could easily do it by locally palpating the tendon, look for a local swelling of the tendon, and when pain is associated with activity. So when these 3 criteria are present, then you can be confident to establish the diagnosis of Achilles tendinopathy. Then about the management part. So how do we best manage Achilles tendinopathy? We did a very large study on this to look into possible effective treatments. And what we found is that every active treatment is better than wait and see. So it's a bit hard to translate it to the clinical practice.
So when you're saying every active, what does that cover? Because there's a lot of presumably active treatments.
Yeah. So, good question. So I think it can cover everything, and that's also what we saw. It's exercise therapy, passive modalities, injection therapies. Surgery wasn't included because there are no randomized trials on surgery. But I think you could cover a lot of conservative treatments, and we were able to make 180 comparisons between treatments. So there's a lot out there, but the fact is that we didn't find any major differences between active treatments.
So the resistance training that is prescribed for patellar tendinopathy is not better in Achilles tendinopathy?
Well, you could look at it both ways, because you could say it's not better than injection therapy. But then I think what is important to consider, if their efficacy is comparable, how's their safety profile, how feasible are they, and what are healthcare costs? And I think from that perspective, loading therapies have a bigger advantage compared to, for example, exercise or for injection therapies or other passive modalities. So that would always be the starting point for me.
So how is the work that you're doing, how does that relate to the international treatment guidelines? Is that, I don't know actually, who makes the international treatment guidelines for tendinopathy? Is that in part of the ICD system somehow, or what scientific community guides that worldwide?
Well, no, there's not a really guide, and I think there are several national guidelines, and we also search for that in our process. And the main guideline we found is one from America, and it's slightly different, I think, in its approach. But and therefore I think we have a bit different outcomes there. But in fact, the core seems to be the same, is that you start with conservative treatment, and in the end you could think of surgery when things do not resolve. But I think we have a bit another approach based on our considerations, so more based on our clinical expertise, because the scientific evidence cannot tell us, cannot provide us that many answers that can give a more beneficial, more benefits of a conservative approach over another conservative approach. So I think therefore we need our considerations, our clinical expertise in this.
So are you saying that the different treatments you tested, that none actually seemed to be significantly better than the other ones?
Well, there were two treatment options, and that were the shockwave therapy combined with exercise therapy and the acupuncture therapy that seemed to be to result in a higher clinical improvement compared to other active treatments. But these were two small trials with a high risk of bias, so we need to be cautious with the conclusions. And I think, based on this, you could easily say that they are quite comparable. And also at the long-term follow-up, we don't have any evidence that these are better than other treatments.
Is it meaningful to just group, Achilles tendinopathy is one box to fit a set of symptoms into. Is it meaningful to just put it into one box, or should there be some kind of subclassification included as well?
Yeah, we discussed this in the group as well. So should we subclassify Achilles tendinopathy? And first of all, we try to do it based on location and symptom duration. And we were struggling with the early tendinopathy. This is not really well defined. So in the end, we ended up with a distinction of insertional Achilles tendinopathy and mid-portion Achilles tendinopathy. So the subclassification based on location. And from that point, we worked this out.
So, when you subclassify according to this, does that subclassification influence the treatment paradigm or outcomes in any way? For the insertional, if I again look at purely from the scientific evidence part of the view, I can say that there's only one RCT out there for the insertional one. So there's not so much you can say there. And for the mid portion, we've
identified 25 RCTs, so we can say a lot more from the scientific evidence part of view there. And I think based on our clinical expertise, there are differences between these two groups, and also differences in how you would initiate your treatment.
Is the etiology behind insertional versus mid-portion Achilles tendinopathy different? Is that known?
It isn't known, but I think what you need to consider in case of insertional tendinopathy, that there could be rheumatic diseases that underlie in this process. So it could be part of an enthesitis, and this needs another approach than we see in what we call the overload tendon injuries.
How about, have you discussed in the group subclassification based on different traits in imaging, for example, Doppler activity or vascular activity or nerve ingrowth, or any of like the more biochemical marker rather than functional?
Yeah, I think this is really an interesting field, but we don't know so much about this subclassification based on these biomarkers, and especially for the imaging part. So you can see a lot of co-pathologies like involvement of the plantaris tendon, bursitis, Ekelund morphology, longitudinal tears. There could be a lot of subclassification, but we don't know whether these respond differently or whether they should be treated differently from how we do it regularly. But I think what you're telling about more the biochemical stuff, I think we need future research with more in-depth analysis with blood biomarkers to know more about the condition, what happens longitudinally, what changes over time in the tendon, and how can we explain with these blood biomarkers what happens in the people who are having chronic symptoms, and what happens when people recover. I think that can help us to better target our treatments.
In what ways are Achilles tendinopathy comparable to tendinopathy other places in the body, and in what ways is it not?
Well, I think we see similar pathologies all over. So I think if we compare to a tennis elbow or a cuff problem, I think you see on basic pathology, you see comparable images. So that's the similarity. And I think the differences are how they respond to treatment, I think. And then I think for the lower extremity tendinopathies, I think loading therapies are very effective. For the upper limb, I think, most trials suggest that it is harder to find differences there. Yeah.
But then again, there are more exercise trials for lower extremity tendinopathy. At least as I experience it, is there any, like, the overall amount of evidence on training interventions for upper body tendinopathy is pretty shallow, isn't it?
As far as I know, I'm not an expert in the upper limb tendinopathy, but as far as I know, it's less common in research than for the lower limb. So that's also what we found for the Achilles. The eccentric exercises are by far the most frequently researched intervention, and I think for the upper limb it's far less. Yeah.
So for a lot of people probably have, when you hit the 40s, training starts to hurt more than in your 20s, or if you have accumulated enough years of training, you get these pains and aches, and some of they stick around for a few days, some stick around for a few weeks, but mostly they just go away. And of course these are subclinical conditions, but I'm thinking that they're probably like subclinical. Most of that is probably subclinical tendinopathy in some aspect or another. and I don't know if you agree with that. You're nodding, so I think if you go along with the thought, what is the best advice for all of these like subclinical tendinopathies, if that's what it is?
Well, I think data that we saw yesterday from Dr. Coupé was that the early tendinopathies respond better to treatment, so better to early intervention with load management advisors, patient education, and exercise therapy. And we see if people have more chronic symptoms, they tend to respond less good. And I think therefore early recognition of the disease and intervention will probably lead to a better mean symptom resolution. So I think therefore it's important to early for the early disease detection that people get informed better and that they have less chronic symptoms over time. Yeah.
So what is the reason that people? What is the reason that people develop chronic Achilles tendinopathy? How much of that is occupational and how much is recreational? And I have more questions, actually. I'll take those afterwards.
Well, I think for the Achilles is most of the time associated with sports activity. There's a subgroup of more sedentary people. They do have symptoms more all day around and also related to more walking activities. But it's not so often occupational in the Achilles. I think for the upper limb you see more occupational problems, especially the tennis elbow. And I think for the Achilles is most of the time related to sports activity, and especially in runners you see it more often. Yeah.
How strongly is body weight related how strong a predictor is body weight as a predictor of Achilles tendinopathy?
We did a large systematic review on the risk factors for Achilles tendinopathy, and body weight was not, or BMI was not associated with Achilles tendinopathy, which you would expect. But it didn't came around, and it could be because BMI is quite a gross measure, and there could also be people with very low BMI could also be at risk, so it could be leveled out there. So I think in future study we need to have better measures of adiposity. I think fat percentage, for example, is a measure you can easily perform, and perhaps that's a better predictor. So the BMI doesn't tell us all.
How about movement patterns? I know that in recent years, front and fore and midfoot running has gained a lot of popularity with recreational and competitive runners as well, and that moves a lot of the stress to the forefoot and through the Achilles tendon. So they may not get plantar fasciitis anymore, but at least anecdotally, in my own experience, I see a lot of people that exchange their plantar fasciitis for Achilles tendinopathy. Is that just an anecdote, or does that fit with some of the data? Has anyone looked into that?
Yeah, I'm aware of a large Canadian study where they evaluated runners that made a transition from the rear foot to the forefoot landing. And most of these experienced calf and Achilles symptoms, but they didn't really look into how long they experienced it and if it was really a clinical diagnosis of Achilles tendinopathy. We recently performed a large study on running-related injuries with more than 2,000 runners, and they also based on a questionnaire, they told us whether they had a running-related injury. And also, especially for the Achilles, we also collected this information, and we did not find the relationship between the type of landing and Achilles tendinopathy. So you would expect, indeed, forefoot landing is a risk factor, but we couldn't find it. And it could be the reason that if people have to define their landing type themselves, they could be wrong. I'm aware of one study where they could not tell themselves whether they are forefoot, midfoot, or rear foot landers. So that might be an explanation.
Are there any other like movement pattern? Then I'll rephrase. Is there any like movement predictors at all for Achilles tendinopathy?
Well, there's one Belgian study that shows that where they did a gait analysis in 50 people, and 10 of them developed an Achilles tendinopathy over time. And they found two factors. One is that there's a more lateral foot rollover, and one other is that there's a decreased progression from posterior to anterior during the push-up phase. And these are two variables in a small population, so I think there might be some bias in there and some statistical problems. So I'm not sure whether it is really of importance for all patients to have a gait analysis based on this study.
That's pretty interesting. Do you think this whole... I mean, that's seen a lot in epidemiology, that when it's hard to connect traits to outcomes. And when you do large-scale epidemiology, you tend to get some... I mean, the associations are weak, if at all present, and the confidence intervals are very wide. Do you think then in doing that kind of research, you may lose out of some of them in some specific cases because the science tends to even out everything? Does it make sense what I'm asking?
Yeah, so I think if you would do such a study, you need large numbers. So that's the only thing you need to be sure of. Otherwise, you cannot make relationships, and especially when you do a lot of measurements, you need large numbers, and that's hard. We're trying to do it now in the Erasmus to set up a very large cohort where we see them at baseline for a lot of measurements. But you need a lot of funding. That's the whole thing you need to achieve, to have a lot of funding to do all these measurements and to follow them up adequately. Yeah.
Last question. How far are we concerning the genotypes? I know that some genetic polymorphisms in collagens, at least in some studies, have been associated with the risk of developing various tendon problems. How far are we with that? And is it common enough that for it to be something that should be considered at all?
Yeah, I think it's, especially as you were telling, there are some associations with the specific COL5A1 genes. I'm not really looking into this, but I think that's a very interesting field, and perhaps one further step is that you can also look at different levels, like the expression of mRNA or of specific biomarkers that can help us to better understand what's happening on a clinical basis in, for example, high-risk population of runners. So I think we need to do more research in this part, but I know some groups are working on this as well. Yeah.
Thank you very much. I think that will be all. Can you just again give our listeners your name and where to follow your work if you on Twitter or ResearchGate or something like that?
My name is Jan de Vos, sports physician from the Erasmus Medical Center Netherlands. And yes, you can follow me on Twitter and LinkedIn. I'm not sure. I don't know my address by head, but
Jan de Vos.
RG de Vos, I think it is. But you can find me on Twitter. No, it shouldn't be a problem. Yeah.
Det var Jan de Vos, læge og Ph.D. fra Holland af. Den næste, vi skal have fat i, det er Steven West. Steven, han er Ph.D.-studerende i idræt fra England af. Bath, tror jeg nok, det var. Og han holdt et oplæg omkring det her med at måle træningsbyrde i sporten. Han var en del af en session, der var dedikeret til at diskutere det her med at måle, ligesom det her med, hvor meget man kan træne. I elitesport, i hvert fald i nogle elitesportsgrene, der er der jo en kultur for at træne rigtig meget, og man vil også gerne vide, ligesom, hvad er den rigtige mængde af træning. Fordi man vil gerne træne så meget som muligt, men man vil ikke træne så meget, man overtræner. Og det findes der har været en masse forskellige forsøg på at udvikle både subjektive og objektive værktøjer til. Jeg ved, i Danmark, der brugte Team Danmark på et tidspunkt sådan et system, der hedder Omega Wave, hvor man forsøgte nogle objektive markører, sådan noget, hvordan elektriciteten over huden var og sådan nogle ting. Og der findes også en række subjektive markører, altså hvor hårdt synes du træning er beskrevet på forskellige måder. Og det er sådan, det er grundlæggende så er det et interessant spørgsmål. I virkeligheden ikke kun for eliteatleter, men på en måde også for mange af de elitemotionister, der er. Fordi der er mange nu om dagen, der forsøger at presse så meget træning som muligt ind i et liv, hvor der er stressfaktorer for alle mulige andre ting. Man har et arbejde, og man har nogle børn, og nogle samfundsmæssige krav til, hvor man skal agere, der alle sammen kan bidrage til, hvor hårdt det er. Det kan også være, at man sover dårligt, eller man har eksamener, eller man kan sige, at rigtig mange elitemotionister er jo studerende, så det er måske i virkeligheden det mest realistiske scenarie. Altså, hvordan håndterer man det samlede stress, og hvordan måler man sit træningsstress i forhold til. Så derfor synes jeg, det var et interessant en at høre, hvad jeg havde at sige om det. Han kommer her.
Jeg står her sammen med Stephen West, som har været en del af sådan en session, hvor man har talt om at måle arbejdsbyrden eller træningsbyrden i forbindelse med elitesport med henblik på at måle skadesrisiko. So thank you, Stephen, for taking a couple of minutes to talk with us here. Our podcast is called Fitness MK. And we sadly just missed your talk because we were at another one. But this whole concept of measuring training load, I mean, we're in a time where there are more devices accessible and cheaper than ever before of measuring the objective burden of stress. Is it actually doing any good?
Yeah, so I think today we've heard a couple of interesting talks as to what we can actually use training load for or load monitoring for. I think from my perspective, I think it's a useful tool. I think it can't be oversold in what it can do. It certainly can't predict injuries, but I think what it can do is it can objectively help a coach to make a decision that they might subjectively be thinking. So it supports potentially some of their decision making. But as well as that, I think it starts a conversation with an athlete, and that's the main thing. So you might not be able to detect something other than what you might see in the data, and then you can go and approach that athlete and actually make a decision about how they're feeling. So it might actually show something that they're not physically showing. So I think that's quite important. I think irrespective of what resources you have available to you, there's a way of capturing load, and I don't think it should be confined to just the elite space. There's simple ways to do it at a community and a youth level, and I think trying to identify the difference between internal and external loads. So external being the work that's being done by the athlete, and then the internal being the response of that athlete to that external stimulus. So I think there are some really key things, and I think as we go forward and wearables and technology advances, we need to make sure that it's actually able to answer some of the questions that we have, rather than just doing it for the sake of because we've seen somebody else doing it.
Can you say something about your own research using stress biomarkers or load biomarkers?
Yeah, so my work has been over the past 4 or 5 years has been in rugby union specifically in the UK. So we've been working with the English Premiership rugby clubs, and we've been collecting load and injury surveillance data over that period. And again, one of the challenging things for us is that in rugby we get a lot of different types of stimulus, and not all load measures are able to record in certain settings. So you can't use a GPS unit to record your gym-based training or your gym-based load. So we use session RPE because it was applicable across lots of sports. It was being widely used.
So just to get the listeners, rating of perceived effort.
Yes, rating of perceived exertion. So after each session, we had practitioners that were working with us from each club, and they would ask the athletes what their rating perceived exertion for the whole session was.
A standard 10 scale.
Yeah, 10 scale RPE, and then we would then multiply that by the session time to give us a session RPE score for the entire session, and that was the load score for that session. These were then summed across days, weeks, months, and so on. And essentially what we started doing was we started thinking about how that information interacted with other risk factors, so things like age, position, previous injury, previous concussion, the number of match minutes that they'd played over the last 12 months, all of these kind of factors that all play a role, and how we could potentially start giving that information back to clubs and coaches. So as I say, we use predominantly session RPE, but in the kind of later stages we advanced on to GPS metrics, just because I think it's pretty commonly used in rugby union, but across lots of different sports. And yeah.
The GPS in both in rugby training and in games?
So we used GPS from training and games. Obviously not for gym-based training or anything like that, but we had it for all training, all matches in a cohort of 6 clubs who used common units, common definitions for defining their variables and so on. And we focused on high-speed running and total distance, just because they were the 2 most commonly used variables. So we matched that with the RPE because, as I say, the GPS doesn't get the whole measure or the whole picture because you miss the gym, which is a big part of rugby. But then we have done smaller studies looking at the England Sevens rugby team, where we looked at other measures of GPS as well. So things like decelerations, accelerations, as well as other, not physical loads per se, but things like sleep quality, sleep quantity, travel, heart rate variability, daily well-being scores. So that was a more holistic picture of load, but that was just because the sample size was smaller and it was more feasible for us to do it. When we were dealing with 700 athletes a day, it's pretty difficult to get all of that information together in a bigger cohort. So yeah.
And does that did that information result in some kind of algorithm where you can flag at-risk athletes?
Yeah, so I think it's pretty difficult for anybody to be able to produce an algorithm to kind of flag those athletes. But what we can then do is we can take all of that information to start making an evidence-based decision around risk. So we can see that maybe their training load is a bit high, they didn't sleep very well last night, they're under pressure from a contractual point of view, maybe at the end of the season. So we start thinking about those things, and then we start to think about other contextual factors such as the time in the season. Is it an important match? How important is the player to the overall performance of the team? And all of these other things, and it allows us to start making better decisions, looking at the whole picture rather than just isolating training load per se to make a decision about the player.
How about blood-based biomarkers? I know that some of the blood-based biomarkers at least correspond pretty well with some of the internal or some of the external, like cortisol or creatine kinase or something like that.
Yeah, so it's certainly not an area that I've personally looked at. Again, just because we have such a big cohort of players that it's very difficult to look at. I know there's some really interesting stuff out there looking at kind of information around muscle damage and fatigue and stress around that area. But as I say, it's not something that we've looked at. I know there are studies ongoing, but just not. Personally, I haven't dealt with that myself. This has some degree of tie-in to this whole concept of quantified self in the self-monitored fitness or sports community, where a lot of people are under the impression that they can enhance their game of sorts by monitoring more stuff. But from this is a devil's advocate point, of course, but one could make the point that the kind of information you're getting from these various biomarkers, it doesn't actually contribute to what the coach would actually know about the athlete. Yeah, so again, I think it's quite interesting. You see a lot of kind of like inconsistent results between papers, and there's a lot of methodological reasons for that, but there's also just inconsistent, findings associated with something like training load. So I think we need to make sure that when we're as either, general population looking to use something to monitor how they train, or whether you're a professional team, you have to understand the limitations of the products that you're using, or the wearable technology, or the biomarkers, or whatever the case is. You have to understand that we're still at the early stages in terms of training load, and we've got a long way to go. And I think,
So
not to be done.
So in order to put the devil's advocate to rest, what is in your experience looking with the rugby players and the biomarkers you mentioned, what is the single most usable finding that you could present to the rugby coaches and the rugby union?
That's a great question. That's a golden question. I think knowing what I've done over the past few years and knowing the limitations of training load, I think it's important to realise that, training load is not going to predict injury. Training load is not going to solve all of your problems, but it allows you to start a question or start a conversation with a coach, or start a conversation between a coach and an athlete, so that you can understand if there's something going on behind the scenes that you can't see physically that might be causing either a dip in performance or potentially higher injury risk. So I think don't use it to predict injury, but use it to start conversations and identify potential dangerous trends for either performance or injury.
That's a good answer. Thank you. Can you just tell our listeners your full name and your title and your affiliation?
Yeah, so I'm Dr. Stephen West. I'm part of the Injury Prevention Research Group at Bath University in the UK. So yeah.
Thank you for your time.
Not at all, thank you.
Det var Stephen West. Det sidste interview, vi har fra Sportskongressen, i den her omgang i hvert fald, det er med Ulf Ekelund, som er en norsk læge og professor, som arbejder med sådan noget fysisk aktivitetsepidemiologi, altså sådan noget med, hvordan fysisk aktivitet det påvirker dødelighed. Det er jo sådan alment kendt, at det er godt at være fysisk aktiv. Og der er rigtig mange, der træner rigtig meget under påskud af, at det er godt for sundheden. Men der er ikke særlig mange, der er særlig godt bekendt med, hvor sundt, eller hvor meget der skal til, for at det er sundt. Og det er ret interessant i virkeligheden, fordi jeg rejser selv rundt og holder nogle foredrag sammen med min kæreste, Katrine Gissiger, hvor vi blandt andet taler om det her. Der er rigtig mange, der nemlig har en forståelse af, at der skal rigtig meget træning til, for at det er sundt, for ligesom det er optimalt sundt. Og det går faktisk lidt imod den forskning, der er lavet på det. Et eksempel på det er det her med de 10.000 skridt om dagen, som der er mange, der tror, det er det der er målet, hvis det skal være sundt. Og så med alle mulige andre ting, man kan gøre, der har en indflydelse på sundhed, så er der sådan en mætning et sted. Der er en mængde af den her sundhedsting, man kan gøre, hvor ikke man får mere smæk for skillingen. Og der er det sjove, at når man kigger på forskningen i det her med skridt, så ser det ud til, at den allerede et godt stykke før de her 10.000 skridt per dag, så er det måske en 6-7.000 skridt per dag. Og det betyder meget, fordi der er mange, der internaliserer det her med, at man skal jo være så sund som muligt, så skal man gøre alt det rigtige, og man skal gå 10.000 skridt om dagen. Men hvad nu, hvis det ikke er 10.000 skridt? Fordi det er det nok ikke. Så det er nok kun 6-7.000, der skal til, for man er mættet, hvad angår sundhedseffekten af skridt. Så det synes jeg var det der er interessant her. Og det er det, som hans forskning specifikt har bidraget med. Det er fysisk aktivitet målt med accelerometer. Altså hvor det ikke er sådan noget selvrapporteret, hvor meget har jeg gået. Og det synes jeg er ekstremt interessant, det man præsenterede på konferencen. Det er Ulf Ekelund, han kommer her.
Ja. Yes, I'm standing here with Ulf Ekelund, who just presented this morning at the conference. Could you just please present provide us with your full name and your title and your affiliation before we get on further?
Yes, thanks for inviting me. My name is Ulf Ekelund, and I'm a professor in physical activity and health at the Norwegian School of Sports Sciences, originally from Sweden, and did a 10-year work in Cambridge in England before I joined the Norwegian School of Sports Sciences in 2012.
So you gave a talk about the dose-response relationship between physical activity and health effects provided as mortality. I presume I missed the talk because it was very early in the morning. But can you tell our listeners just briefly how the overall dose-response looks?
Yeah, I mean, we have known that physical activity is beneficial for a number of health outcomes, and we've known for probably 50 years that higher levels of physical activity reduces the risk of mortality. I think one of the first papers was published in about 1978, showing a dose-response association, suggesting that higher levels of physical activity was associated with a reduced risk of death. And the maximal risk reduction was about 30% for those ones who did quite a lot of physical activity. It was equivalent to about 10 to 15 hours of walking per week to obtain that maximal risk reduction. And that has been replicated in many studies since, both in men and women, individuals from high-income countries, low-income countries, middle-income countries. And most of those studies suggest the dose risk or maximal risk reduction of about 30%, but at quite high levels of physical activity, about 3 to 5 times the current recommendations of physical activity.
how does the effect of recreational physical activity compare to the effect of occupational recreational physical activity?
Just to continue on what we said. Those previous studies using self-report have mainly looked at leisure time or recreational physical activity. What we did in our study was that we combined data from 8 different studies where physical activity has been measured by accelerometry. So we had a device measure of physical activity which is more accurate, more precise, and what we saw in our study was that the maximal risk reduction was substantially greater. We saw a risk reduction of about 60% for much lower levels of physical activity. So we found that if we think about moderate to vigorous physical activity, which is equivalent to brisk walking, about 24 minutes per day of moderate and vigorous physical activity equivalent to brisk walking was associated with about a 60% risk reduction, which is substantially different from previous studies, and it's, I think, a very important public health message. We don't need to do substantial amounts of activity. I mean, the current recommendations of about 150 to 300 minutes per week is fairly accurate for those findings we had from our study.
So in your accelerometry data, is that for all data accumulated data or just leisure time?
No, that's all data accumulated from early in the morning to late in the evening. So I think the average measurement time in that study, including 36,000 individuals, was about 15 hours. So we measure physical activity for about 15 hours per day.
So when you're seeing a greater difference in that study compared to previous studies, is that an indicator of the people that have a greater recreational physical activity also actually have greater occupational physical activity, so it underestimates the true physical activity throughout the day?
Well, I think self-reported data is probably associated with some errors. Social desirability bias, for example. People tend to over-report the amount of physical activity, and they may underestimate the amount of sedentary time. So I think that contributes to the difference between our accelerometer data study compared to previous self-report studies. But whether those ones who are highly active are active during occupation or during leisure time, we actually don't know, because we can't really separate occupation from leisure time physical activity in accelerometer data. But overall, I think the message is that higher levels of physical activity is obviously better, but you don't need to do that much of activity. Another interesting finding was that we also found that light intensity physical activity, which is not included in the current recommendations, was associated with risk reduction for all-cause mortality. And I think that's important as well, because every movement seems to count. So everything, all things we actually do as soon as we are physically active seem to have a beneficial effect on health.
So when you're using accelerometry-based data, how much do people have to move in? Because you're describing minutes. So how much do they have to move in order for it to count as movement in that setup?
Oh yeah, those accelerometers measure basically all movements. If you're sitting down or laying still, there is absolutely no registration of movement. But as soon as you start to move just a little bit, stand up from a desk, from a chair or something like that, then there is a registration of that movement in the data.
So if you had, I don't know if you had GPS data as well, but I'm just asking, I'm thinking about whether the total amount of active time is as good or worse or better correlate with mortality than distance moved or estimated energy usage or something like that.
Yeah, no, that's a good question. We didn't have any GPS data, but I think there is a very high correlation between total movement from an accelerometer and the distance you have moved. The problem with GPS data is that it's quite difficult to measure movement indoors. I mean, you can measure it accurately outdoors. But there was also another study published last year looking at number of steps taken in elderly women, 70-year-old women from the US, a large study including almost 17,000 women, and they also found a very nice dose-response association between number of steps taken and all-cause mortality. And interestingly, the number of steps where they observed the greatest risk reduction, if I remember correctly, was about 5,000-6,000 steps per day.
I think a lot of evidence points at higher intensity exercise, at least contributing somehow more to various health outcomes. And I know that some of the studies and meta-analysis done on the subject, they try to account for that by counting med hours, where you kind of 2 hours, 1 hour of double the intensity counts in the same way as 2 hours of half the intensity, that kind of stuff. Do you think that's a meaningful way to account for exercise or the activity intensity, or does it over or underestimate the effects of being active at a high intensity level?
No, I think being active at a high intensity level is probably or is beneficial. In our study, we found stronger associations for both moderate intensity and for light intensity compared to vigorous intensity, but that's explained by very few individuals in our studies.
So it's a statistical issue. Probably.
Yeah, they very few individuals performed any vigorous intensity activity. So, but there are studies suggesting that high intensity activity is beneficial for a number of metabolic outcomes. But there are few studies looking at, or I don't think there is any high quality study with device measured physical activity suggesting that vigorous intensity might be needed to reduce the risk of mortality. But in the general population, unfortunately, few individuals do high intensity activity, but for those who do, they should obviously continue doing it.
But do you think it's a fair estimate to say that activity at twice the intensity is twice as good?
I think that's difficult. If I look at our data and having all-cause mortality as the outcome, we observe the maximal risk reduction at about 23 to 24 minutes per day for moderate intensity. But if you compare that to light intensity, the maximal risk reduction was similar in magnitude, but you needed to do about 300 minutes. So then you compare 23 minutes of moderate against 300 minutes of light intensity, suggesting that moderate intensity, the time difference is substantial. It's six times. You do a sixth of light intensity. If you do that in moderate, you have the same risk reduction, more or less.
And that's per day?
That's per day, yes.
300 minutes per day?
300 minutes per day. So that's, that's 5 hours. 5 hours of light intensity per day.
And exactly how intense is light intensity by that in your definition here?
Well, light intensity is slow walking, some household work, so it's just moving around basically.
Several of the other dose-response studies that look at like the dose-response of physical activity compared to mortality, several of those see an increase of the curve again at very high intensity levels. What is your thoughts on that finding? Because it's not just a single study. Several studies actually find that, but not everyone.
I think that's most likely a statistical artifact, because that increase at the right end of the dose-response curve is probably due to very few individuals in that high level. We saw exactly the same thing for moderate intensity. There was a slight increase at the higher levels, but that was due to, and the confidence intervals were wide, but we have very few individuals doing, let's say, 60-70 minutes of moderate intensity per day in our study. So I think that's it has been shown, as you said, has been shown in many studies, but I think it's most likely a statistical artifact. Few individuals at the very high end of the activity scale.
Do you think it could be related to the phenomenon of a middle-aged, midlife crisis men that start doing excessive amounts of triathlon and marathon training? Because there is some science showing that they are overrepresented in various cardiovascular events in relating to the sport.
Yeah, That might be the case, but I don't think that shows up in these kind of population-based studies because they are so few. Those individuals who takes up those extreme endurance activities, like as you said, marathon and ultra marathon and triathlon, they are so few, so they won't change the curve as we see it. So I don't think it can be explained by a few individuals doing quite a lot of extremely amounts of activities.
I'm just counting because if you say that the number of individuals showing up in the epidemiological studies as super high intensity, if those are very few, then those very few people becoming mammals, as they're called, could influence it possibly.
Yes, but on the other hand, I mean, there was one presentation from Kim Blunt in our study, and they did a in our session, and they did a systematic review on and tried to really address this question with high intensity and whether the shape of the association is U-shaped. And in that study, we combined data from more than 40 different studies. They hardly saw any U-shaped relationship. And most importantly, we may think that if you do high intensity activities, that might be dangerous for your heart. But basically, when they looked at cardiovascular disease mortality, there was no increase at the right end of the curve. It was basically going down more or less with continued or higher amounts of activity.
Thank you. Can you just sum up the core of your finding? Because I think that's actually, it's a stronger model using accelerometry, and I think the findings are very relevant. Can you just put it in, bend it in neon for the listeners?
Yes, no, I think the main finding is that all activities counts. Every single intensity of physical activity is associated with a reduced risk of mortality. I don't think you don't need to do as much as activity as previous studies have shown from self-report. The current recommendations of about 150 to 300 minutes of moderate intensity activity per week seem to be fairly good, at least if we consider all-cause mortality. And just to summarize, the public health message should be to sit less, move more, and the more the better.
And 23 to 24 minutes a day, 30% risk reduction. Was that was the numbers, right?
60% risk reduction. 60% risk reduction at about 23 to 24 minutes of brisk walking per day.
So I think that's about the same difference as the difference between not smoking and smoking 5 cigarettes a day or something like that.
Could be. I think. I don't remember exactly from the top of my head the risk reduction for smoking. But if you compare smokers with non-smokers, I suppose the hazard ratio is probably 2 to 3 times greater for mortality in smokers compared to non-smokers. But a few cigarettes per day might be the same. Yeah.
I think it's about that.
Yeah.
Thank you for taking your time to talk to us. Can you just again give us your full name and your title and affiliation?
Ulf Ekelund, professor in physical activity and health at the Norwegian School of Sports Sciences, Oslo, Norway.
Thank you for talking to you.
Thanks.
Det var alt, hvad vi havde fra Sportskongressen den her gang. Der kommer også en sportskongres til næste år. Den ligger i januar eller februar hvert år. Og det er altså nok, det er i hvert fald Danmarks største og en af Europas største kongresser inden for idrætsmedicin og sportsfysioterapi. Og vi håber på at få lov til at komme igen til næste år. Der er i hvert fald rigtig mange spændende oplæg. Det handler meget af det, er jo sådan noget klinisk noget om skader og sådan. Der er også noget, som jeg håber, I har fået et billede af, der handler om træning. Desværre så har vi ikke en videnskabelig kongres til træningsvidenskab i Danmark eller i Skandinavien. I hvert fald ikke en tilbagevendende en. Så meget af det havner på Sportskongressen 2020. Jeg vil gerne sige tak, fordi at Fitness MK kunne få lov til at svinge mikrofon på Sportskongressen. Det har været en god oplevelse, og der er så mange søde mennesker. Så det vil jeg gerne sige tak for. Og hvis man sidder derude som studerende eller interesseret, så kan jeg anbefale, og jeg kan faktisk slet ikke anbefale det nok. Det er en af de bedste videnskabelige kongresser, jeg har været på overhovedet. Så det kan jeg ikke anbefale nok. Det er lidt dyrt, men alt er jo relativt, så jeg vil mene, at det godt kan være pengene værd. Så mig afsted. Ja, det var Sportskongres, afsnit 2 ud af 2, og der kommer forhåbentlig også en Sportskongres 2021. Du har lyttet til Fitness MK. Jeg hedder Anders Nedergaard. Du har lyttet med til den her og de andre episoder af Fitness MK via stream og podcast. Man kan streame det inde på andersnedergaard.dk eller hos Libsyn, og man kan podcasten fra alle de store podcasttjenester. Programmet er produceret af Jonas Pedersen, og man skal være velkommen til at skrive ind til os, og det kan man på afn@andersnedergaard.dk eller på programmets Facebook-side.